Hi, my name is Manesh Patel. I'm here again with a friend and a colleague, Mike Gibson, and we're going to be talking about some challenging cases applying the knowledge we have on patient care for prevention of stroke. Thanks for joining me, Mike.
Thanks for having me again, Manesh.
All right, let's get into it. Let's meet Sarah, our first case study. She's 78, female with recurrent dizziness, fatigue, and concern about previous bleeding episode while on anticoagulation. It's important to recognize in our case review, we often go through her medical history, other history assessments, and then personalized treatment plan as we do. Mike, I guess I'll start by saying, given Sarah's age, she's 78 with a prior GI bleed, how do you initially assess whether her stroke risk outweighs her bleeding risk in someone who's not on an anticoagulant right now? And certainly she sounds a little hesitant to it for the reasons we've discussed.
Yeah, complicated patient, right, Manesh? I mean, GI bleeds occur at a spot where we can't compress them. They're often fatal. Some of the choices we have out there aren't great for GI bleeding, rivaroxaban being one of them. The Apixaban also has a little GI bleeding. Low-dose edoxaban, the 30 milligram dose, is one that does not have excess GI bleeding, which could be a good choice here. But again, the art of medicine is giving the right patient the right drug at the right dose.
Yeah, Mike, and some of it's talking to her, as you said, about how this has happened and what the issues are, and then what the relative risks, or at least the absolute risks, are for each, and what she might think of that. Well, her medical history, she's got AFib, she's got hypertension, CKD stage 3, she's anemic. She had 2 years ago had a GI bleed while on warfarin. Current medications include lisinopril and iron sulfate. Apixaban was discontinued, as you said, when she had this episode happen with the bleed. So I think there is some opportunity for us to continue to think through this and understand about that history, if you will, for her. Just moving forward into that, one might say, in your experience, the most common reasons patients like Sarah fall through the cracks when it comes to guideline-directed medical therapy. We see a lot of them here just in her case history. She probably represents some of those that you've seen, Mike.
Yeah, I mean, bleeding, I got to be honest, kind of scary. If you have GI bleeding, it's very much a concern. Yeah, one of the things to do here is figure out, why did she have the GI bleed? Talk to a gastroenterologist. Maybe she needs to get scope. Obviously, getting rid of aspirin and substituting another drug, getting rid of nonsteroidals, alcohol, all the reversible factors would be critical. But see if you can get her back onto the balance beam with respect to anticoagulation.
Yeah, Mike, I love the balance beam analogy. We've been talking through some, one side or the other. You don't want to fall off one or the other. And she certainly feels like she's fallen off on the bleeding side. And so we want to see that. When we ask about what kind of support structure and other things she has in her life, her history shows that she lives alone. She doesn't drink alcohol or use tobacco, as you said. She's a retired school teacher, and God bless her, because that's hard work and we need more of those. Her father had ischemic stroke and no known bleeding disorders, and she has had a cholecystectomy. In clinic, her blood pressure is reasonably well controlled at 132/76. Her heart rate is a little high at 96, irregular, and AFib, and she's saturating okay. Doesn't have any murmurs, no abdominal tenderness or melena that she's noted, and then she's alert and oriented with no focal deficits or any evidence of a prior stroke. Her electrocardiogram shows she's an AFib, and just a single shot of her echo shows, obviously, that their atrial sizes are large, and there's at least a little bit of mitral regurgitation there. We'd have to see how much there is on actual moving images, but she's got at least an enlarged ventricle a little bit. It looks like an enlarged atrium and some mitral regurg. Her CHADS VAS score, she's 78, so she gets 2 points for that. She's a woman, she gets a point for that. She's got hypertension, she gets a point for that. She's got some vascular disease history with aortic plaque and others. So she's got a reasonably high CHADS VAS score of 5 here. There'll be some controversy about just how much stroke risk the sex of female sex is. There's ongoing conversation about that really moving the score. The vascular disease history, how much of that moves the score and how much vascular burden you need, that's an ongoing conversation. But even if at some of those features, she's got a pretty strong 3 to 5 range, and I would say clear indication if she wasn't hesitant for anticoagulation in some fashion. So, Mike, do you routinely use stroke and bleeding risk calculators to guide your treatment decision, or are there other factors you use more in your practice?
I think, there's been some hesitancy about the has blood score. People backed off a bit about that. I think, the risk factors for bleeding are pretty well known. So I think, like most docs, use your clinical experience. And, again, it's a shared decision making process with the patient. Another option to consider here outside of drugs would be a left atrial appendage occlusion device.
Yeah, I think that this is like you said, a really important conversation you're going to have with her to understand that. And we haven't gone into all of her other medications, but is she on NSAIDs? Is she on an antiplatelet for whatever reason? I think her stroke risk is high, and I certainly think having the conversation with her to understand that's important.
And she's fainting, she's getting dizzy, if she's at
Yeah.
low risk, we need to take that into consideration too.
And as you said, Mike, even though we don't recommend it in the guidelines, people sometimes will use the HAS-BLED or at least walk through that. Hypertension's present in both. So, again, you're going to try to modify that. She does not have any renal disease. She doesn't have any liver disease, although renal disease might go both ways. We can talk about that. She hasn't had a stroke history. She does have a prior major bleed in that GI bleed. She is older and she is, participating or at least having some potential risk medications there. So, I think in her HAS-BLED score, she's not drinking alcohol. That's great news. So, it's 4, her CHA2DS2-VASc is 5. It's not a one-to-one conversation. Some of the risk factors are the same. You really want to modify what you can in her. So when I look at this, I sort of think the big opportunities are making sure that she's not on other things exacerbating the GI bleed. Has the GI bleed been definitively treated? Was there a polyp? Was there an ulcer? Those are kind of the questions that I'm sure are going through your mind. Would you consider her for these ongoing factor 11 inhibitor therapies? Let's say one of those is available on the market. Would you consider her for that, assuming it was available? And what characteristics make her a strong or a weak candidate in your mind, Mike?
Yeah, I mean, obviously, assuming the drugs are successful in phase 3, definitely. She's someone who has both a risk of bleeding and a risk of ischemic event. So a factor 11 could be a good choice for her.
Yeah, I think she would be potentially a great choice if we have one of those with the effective therapies that we want. She's an example of somebody that's falling through the cracks. So you would evaluate her for that if she was in a clinical trial to see if she could be in that, or a low dose anticoagulant alternative. Really, it's just if she could be in the trial or be back on a therapy. I probably would get CBC renal function, do a Falls assessment. She's 78, looks and seems pretty active, but would be sure of that. Bleeding risk mitigation with reduction in antiplatelet NSAIDs. She's not drinking, making sure she understands the risk of stroke, and then making sure she, if she needs any, as you said, if she opts for a procedure like a left atrial appendage occlusion or something like that, we would maybe consider referral to EP. In deciding to restart anticoagulation for her, do you manage it any differently than you might have 5 years ago, Mike, or is it about the same for you?
I think it's probably about the same. I would say, again, I would emphasize that low dose edoxaban, the 30 milligram dose, is the one dosing that has been shown to reduce the risk of GI bleeding relative to the warfarin. So that could be keep her on the balance beam here. I think we are gathering more information about left atrial appendage occlusion as an alternative in people who might not be able to tolerate oral anticoagulants. That's something that's kind of gathering momentum. Still a lot to learn there about efficacy. Yes, maybe some trends to reduce bleeding stroke. On the ischemic stroke side, I think we still have to be convinced that approach is as efficacious as the factor 10 inhibitors.
Yeah, absolutely, Mike. I think we would probably, just as you said, have similar restarts with obviously maybe not starting on the same medication, making sure the GI bleed's been managed, and walking her through why you're doing what you're doing with the other restarts, if you will. So what have we learned in the real world patient care? I guess some key takeaways. This case hopefully helped you all think through what we've been talking about. Clinical decision-making and stroke prevention really has to have bleeding history, comorbidities, patient preferences, stroke risk, all of that tied in. We went through that with her, I thought, pretty carefully. we have a new class of drugs that are being studied, and if they in fact are shown to be safer and have that efficacy, she might be a candidate for that compared to the traditional anticoagulation that may pose a higher risk for her. Obviously, all of this is dependent on shared decision making, which is used all the time. I think the keys is not new. We hopefully have been doing it for a very long time, where we explain the risks and benefits of things to patients. They tell us their values and goals, and then we give them our recommendation. Often comes back to, after they talk to us, what would you do, doc? What do you think? And then we describe it back in the language of what they want and how these therapies might help them. And I think that's critical to optimizing outcomes. So I guess I'll end by saying, we're starting to see more and more patients with precision-based strategies. How comfortable are you in interpreting and applying genomic biomarkers in your AF treatment plans, Mike?
I think it's a very promising area. I think there's both the genetics that play a role, but I think, in addition, there's the exposome. What are you exposed to in the real world? So I think it explains part of it, but certainly not all of it. And her name's Sarah, S-A-R-A-H. I'd say SA stands for start anticoagulants, but the R-A-H, but reduce acute hemorrhage. So, I think her name encapsulates all the things that we're trying to do here.
Yeah, thanks, Mike. That's fantastic. And I agree with you. There's this Nature paper that identifies that, I guess, after age 5 or 6, 12% of your lifetime risk of anything is genomic, and 88% is probably the exposome or the environmental things that you've highlighted that then lead to other biologic changes. So certainly something, as I like to say to patients, it's never too early, it's never too late. We can modify our health and doing lots of things. Thank you all for joining us as we walk through this conversation about how to think about stroke prevention with a case study.